Hi everyone. It's a great pleasure and honor to share our experience in surgical activity in treatment of HCC. I'm Ki Won-sung, a transplant and hepatobiliary surgeon working for Asan Medical Center, Asan University College of Medicine, Seoul, Korea. Today, I'm going to talk about the surgical approach for advanced hepatocellular carcinoma. First of all, I'd like to talk about what's the advanced HCC. The meaning of advanced is a little bit vague. There has been no uniform or universal consensus about that. It's a very subjective categorical term. It might be different from the viewpoint of treatment provider. According to the therapeutic guidelines of HCC, main factors determining the disease status include tumor size and number. The higher number and bigger size usually means advanced stage. In addition, the vascular invasion always means advanced or sometimes far advanced stage. This is a Japanese guideline. The Japanese Society of Hepatology recommended non-surgical treatment as a primary option if the tumor number is more than 3 and vascular invasion exists. They didn't suggest a clear cutoff value of the tumor size regarding the treatment option. This is a Korean guideline. The Korean Liver Cancer Study Group also suggests a similar therapeutic guideline according to the tumor number, size, and vascular invasion. This is one of the most famous therapeutic guidelines used in the actual clinical practice. The Barcelona Liver Cancer Group, the BCLC, the staging and treatment guideline. The Barcelona group categorized the tumor with vascular invasion, nodal invasion, or distant metastasis as advanced stage. In such a situation, they recommended the sorafenib as a primary treatment option. As you can see in this guideline, the surgery, hepatectomy cannot be chosen as a primary treatment option for HCC, the high number, the vascular invasion, or other signs of systemic dissemination. However, the surgeon's interest or viewpoint for advanced HCC is a little bit different. Our major interest is if hepatectomy can be a feasible option or not for the patient. And advanced features from the surgeon's viewpoint include large size and vascular invasion. Huge size and or vascular invasion, such as portal vein, bile duct, or hepatic vein tumor thrombosis, has frequently evoked some argument about feasibility or beneficial impact of the hepatectomy. In such conditions, the role of hepatectomy assigned to the gray zone. So today I'd like to talk about the role of hepatectomy for huge HCC and HCC with vascular invasion, so-called locally advanced HCC. What's your first impression about surgery? Dangerous, painful, destructive? However, the surgeon is not dangerous from the viewpoint of the surgeon. The surgical resection is the most reliable treatment option for hepatocellular carcinoma. It has verified its therapeutic efficacy for a long time and served as a golden standard of treatment for HCC. Nevertheless, there are concerns about technical feasibility and operative risk because most advanced HCCs require very complicated and extensive surgical procedures. Furthermore, the surgical handling can potentially provoke systemic dissemination or spread of tumor cell. So we must have the confidence about the safety of the operation and survival benefit of the hepatectomy to avoid futile operation. Particularly, we must pay attention to minimize the operation risk of patient. So we have to do a very precise preoperative evaluation of the disease status, underlying liver function, and a generalized operative risk of patient. And we need very skillful surgical technique, and we have to apply meticulous surgical technique in the surgical field. And intensive post-operative care is important as well. First, let me talk about huge HCC. Looking at the many reports about the surgical outcome of huge HCC, the early recurrence rate was high as expected. As you can see in this table. But reported long-term survival outcome has shown acceptable ranges. The reported operative mortality has ranged from 2 to 8%, and 5-year patient survival rate ranged from 17 to 15%. The long-term outcome of repeated TAC for huge HCC was much worse than that of surgery. In one Taiwanese study, TACE for huge HCC showed significantly better outcome in comparison with the supportive treatment, but long-term survival rate was very low. In their study, 3-year and 5-year patient survival rate was 12.9 and 6.5% respectively. In the Hong Kong study, the median survival after TACE for huge HCC was just 5.6 months, and we couldn't expect long-term survival in patients with huge HCC and combined underlying hepatic dysfunction. Our hospital have reported our experience of the surgical outcome in huge HCC in 2007. This study included 845 HCC patients receiving hepatectomy. Among them, 107 patients, 14.1%, showed huge HCC. They underwent various kinds of the hepatectomy. The 80% was the anatomical resection, and 20% was hepatectomy combined with the other organ resection. The actual 5-year patient survival rate was 31%, and disease-free survival rate was 20%. In risk factor analysis, the microscopic and macroscopic vascular invasion were significant risk factor for worse outcome. Interestingly, even the patient who experienced the recurrence after hepatectomy for huge HCC showed significant better survival outcome after the active treatment. The gross feature and total number of the tumor can affect the survival outcome after hepatectomy for huge HCC. In the Hong Kong study, the single nodular huge HCC without vascular invasion showed significantly better survival outcome. Therefore, we must actively consider surgical resection as the first treatment option, even in patients with huge HCC. If hepatectomy is technically feasible, the patient can have a chance for long-term survival in selected case. Let me show you the one interesting case. The 46-year-old male patient complained of the right upper quadrant pain. The preoperative CT scan showed huge mass occupying segment 4, 5, and 8. His lip function was normal. There was no evidence of the liver cirrhosis or hypertension. We performed central bisectionectomy in this patient. It was very complicated operation because of huge size itself, and compression of the vascular structure by mass, and deviation of vascular and biliary anatomy. But the operation was successful. The patient has survived disease-free more than 10 years. So whenever we are encountered with the such patient with huge HCC in the clinic, we must think about the hepatectomy first, because most of patients with huge HCC showed preserved underlying liver function. Other local regional treatments are not feasible. Most patients complained of the symptoms which can affect quality of life. Huge HCC always has potential of serious complications such as rupture, bleeding, abscess formation, etc. And the OP risk of hepatectomy has become acceptable recently, even in patients with huge HCC. The next topic is vascular invasion. There has been many controversial issues about the beneficial impact of hepatectomy for HCC with the paraventricular thrombosis. In Coincide, they insist that HCC with paraventricular thrombosis is a high risk for post-resection recurrence and showed unacceptable long-term survival outcome. And they also insist that surgery has high operative risk in such a patient group. In Proside, they question that the outcome of other treatment modalities such as TACE or radiotherapy or RFA can surpass that of the surgical resection, and they also question the increased operative risk by itself, really. In Japanese the surveillance study, we can see the substantial number of the 5 and 10-year survival rate after hepatectomy for portal vein thrombosis. If portal vein tumor thrombosis is limited to second order or third order branch, the 5-year survival rate was 39 and 24% respectively. We cannot expect such result in another non-surgical treatment for HCC with portal vein tumor thrombosis. So hepatectomy might be only chance for long-term survival. In this large-scale retrospective study, they compared the survival outcome between the liver resection and non-liver resection group in the patient with the HCC with the portal vein thrombosis. Liver resection group showed much better outcome, but looking at the patient characteristics, you can see significant difference between the two groups, especially in underlying liver function and tumor number, size, AFP level, and the portal vein tumor thrombosis location and extent. However, the liver resection still showed a significantly better survival outcome, even after the adjustment of the risk factor which may affect survival outcome. In risk factor analysis with the Cox regression, liver cirrhosis, tumor size, and number of tumor over than 3, the AFP level, and location of the tumor thrombosis, and resection margin, there were independently significant risk factor for survival after hepatectomy for HCC with the portal vein tumor thrombosis. In our experience, we can find out the surgical resection enable us to achieve the best survival result even in patients with portal vein tumor thrombosis. In multivariate analysis, the patient age and the gender, the number of tumor and surgical resection were independently significant risk factor for survival after treatment for HCC with the portal vein tumor thrombosis. So, Korean guideline proposed by the Korean Liver Cancer Study Group recommended that the hepatectomy can be considered even in patients with portal vein or hepatic vein or bile duct tumor thrombosis if the liver function is well preserved and the number of HCC is less than 3 and there is no main portal vein invasion. Let me show you another case of advanced HCC with the portal vein tumor thrombosis. This 52-year-old male complained of light plank pain. The pain was very severe. He was the herpesvirus carrier. There was no evidence of the hepatic dysfunction. In the CT scan, the huge HCC replaced the whole extent of light lobe. There was extensive portal vein tumor thrombosis spread to main portal vein, but there was no evidence of the invasion, tumor invasion in left side. So you can see the huge mass in this picture. We did a highlight dissection first, and we divided portal vein. And we also did portal vein thrombectomy and the portal vein venoplasty to prevent portal vein stenosis after operation. And we completed right lobectomy. This slide is summarizing the actual principle in real practice. The hepatectomy can provide acceptable long-term outcome for the patient even with portal vein tumor thrombosis if following conditions such as the no contralateral portal vein tumor thrombus, no intrahepatic metastasis, arterial resection, and no segmental portal hypertension can be fulfilled. Next, I'm talking about HCC with the bile duct tumor thrombus. Sometimes we can see the patient, HCC patient with jaundice. The reported incidence showed very wide range, from 5 to 45%. The hyperbilirubinemia in HCC patient can be classified into two types, hepatocellular type and nictetic type. In hepatocellular type, the hyperbilirubinemia is mainly due to underlying liver dysfunction or extensive hepatic parenchymal infiltration. So 90%, over the 90% of HCC patients with jaundice belongs to hepatocellular type. In such a patient, life expectancy is within 10 weeks. But icteric type is due to obstruction of bile duct by tumor or tumor thrombus. From to 9% of HCC patients belong to this subtype. In such a patient, surgical treatment may be beneficial. Professor Ueda classified icteric HCC into 4 types according to the location and extent of bile duct tumor thrombus. The tertiary order branch involvement belong to the type 1, but segmental branch, the second order branch involvement means the type 2, and first order branch involvement means the type 3. Type 3 biological behavior of types, clinical manifestation and behavior of type 3 icteric HCC is similar to that of the higher cholangiocellular carcinoma. Type 4 means the diffuse involvement of bile duct thrombosis in HCC patient. In his study, he reported that the bile tumor thrombosis affected significantly significant negative impact on survival outcome. The reported patient survival 1 year, 3 year, and 5 year patient survival rate after hepatectomy for HCC with bile duct tumor thrombus was 62 and 30 and 30% respectively. The disease-free survival was very low. The 3-year disease-free survival rate was just 7% in patient group with bile duct tumor thrombosis. We also analyzed the surgical outcome in a patient with bile duct tumor thrombosis. This study included 53 patients with bile duct tumor thrombosis, which accounted for 1.6% of all patients receiving hepatectomy for HCC. Out of 53 patients, 45% of patients were accompanied by the portal invasion, and 60% required preoperative biliary drainage procedure. 92.5% successfully underwent the hepatic resection. Among them, the 85% underwent anatomical hepatic resection. Overall, the operating mortality was 1.8%. In the analysis of survival outcome, we can see it relatively acceptable, the short-term and long-term survival outcome, but over than the 60% of patients eventually they experienced the recurrence. The most common recurrence site was liver, but 20% of patients experienced extrahepatic recurrence, including pulmonary metastasis or lymph node metastasis. But just 20% of patients experienced recurrence at the bile duct, only 7%. There was no peritoneal dissemination after tumor thrombectomy. Let me show you the interesting case, HCC patient with the bile duct tumor thrombosis. This 46-year-old male complained of fever, chills, and jaundice. At the time of diagnosis, the bilirubin level was 13.9, but it decreased, abruptly decreased just after biliary decompression, the PDBD and the EMBD. We underwent the right trisectionectomy and the bile duct dissection. We did the hilar dissection first, and we divided bile duct, and we removed the bile duct tumor thrombus. There has been the controversial issues about the necessity of the routine bile duct dissection in patients with the HCC and the bile duct tumor thrombosis. But because most of the bile duct the thrombosis is not the actual invasion; it's just the thrombosis. So in most cases, it can be easily removed. But if there is any suspicion of the remaining tumor on bile duct wall or any suspicion for right invasion, we must not hesitate to do the bile duct dissection. In this case, we did combine the bile duct dissection. The outcome was acceptable, successful. The patient experienced recurrence after 10 months after the resection, but the recurrent lesion was well controlled by the lipidase. The patient has survived more than 6 years. He is currently alive without the residual tumor on the follow-up CT scan. So, hepatectomy for HCC with foramen tumor thrombus and biological tumor thrombus has shown the worst survival outcome, but hepatectomy might be only curative options in selected cases. But we have to think about seriously think about the technical feasibility and patient the underlying liver function before determining the operation of such a patient. This is summary and conclusion of my talk. In this treatment guideline for HCC, the role of hepatectomy for advanced HCC is very limited, but in real-world practice, the role of hepatectomy for even the advanced hepatocellular carcinoma is still valid. So we have to actively think about the hepatectomy for the primary option, even for HCC with advanced stage. But to improve the post-operative outcome, we desperately need for the effective adjuvant treatment after operation. Thank you for your kind attention.